Very good evening, one and all. It's a pleasure to have our lovely audience out here. Very good evening, fellow doctors. Very good evening, ladies and gentlemen. So, as we all know in our routine clinical practice, one aspect of clinical medicine that keeps coming to us again and again and again in the Southeast Asian population or the South Asian population is the cardiovascular area. The beauty of the Indian genotype is that if I would say it even broadly, the beauty of the South Asian genotype is that we develop CV events at least a decade prior to that of our Caucasian brethren. So understanding disease, understanding cardiovascular disease becomes a mandate in our clinical practice, and hence ECG too assumes prime importance. To understand aspects to ischemia and infarction in an ECG, we have with us our esteemed speaker for the day, and a great educator, Dr. Shashi Gupta himself. I have the honor of introducing Dr. Gupta. Are my slides visible?
Yes, slides are
visible. Yeah. So we have with us Dr. S.B. Gupta, who is a fellow of the American College of Cardiology, the Indian Society of Electrocardiology, the CSI, the Indian College of Cardiology, and the ICP, that is the Indian College of Physicians. He was also the first governor of the American College of Physicians, the India chapter, the past president of the API, the past president of the Indian Society of Electrocardiology, and numerous other bodies. He was also a recipient of many awards and orations, has published many books, has published many chapters in many books, and also multiple articles in national as well as international peer-reviewed journals. He's conducted more than 100 ECG learning courses all over in India, as well as Sri Lanka and Nepal, and has also delivered many lectures in national and international conferences. On the same note, sir, over to you. I hand over the session to you.
Thank you very much, Dr. Parthasarthi. And good evening, friends. Basically, on behalf of Indian Society of Electrocardiology, I welcome you all. The Indian Society of Electrocardiology is about 50-year-old organization, was formed way back in 1972. So we have just completed our 50 years of existence. And as mentioned, we have conducted more than 100 ECG learning courses. And out of India also, we have conducted 2 courses in Sri Lanka and 1 course in Nepal. And I think there are participants who are joining from Sri Lanka and Nepal. So if somebody has attended that course or those courses, may see me again on this webinar. As all of you know, that Indian Society, this electrocardiogram is more than 100 years old. And I think in the present changing scenario, the ECG has still stood the test of the time, though it's 100 years old, more than 100 years old. Still, it is the first choice of investigation in acute coronary syndrome. We cannot have any other investigation and we can diagnose acute coronary syndrome or acute MI without seeing an ECG. So you can imagine the strength of the ECG. And the other place where the ECG has got the role is the diagnosis of arrhythmias. So in acute coronary syndrome and in arrhythmias, ECG is the first line of investigation. And with this note, we are talking today on ischemia and infarction, which is a very important aspect. Maybe we can say for cardiologists, it is the bread and butter for treating such patients. And sometimes it's very difficult to diagnose ischemia and infarction on the ECG. So with that note, I'll just start my presentation. I'm just share my screen. I hope my presentation is visible.
Yes, sir, it is.
So I'll just move on with the topic of ischemia and infarction. And I think the most important thing before you see an ECG suspected of acute coronary syndrome, taking an history is the most important thing. You cannot diagnose ischemia and infarction without taking a history. So the history is very important. You have to have the patient complaining of typical symptoms of acute coronary syndrome, that is retrostellar discomfort, presenting for minutes to maybe for half an hour or so. Associated symptoms may be sweating, dizziness, shortness of breath, or maybe vomiting. So these symptoms are very pertinent. And then apart from just seeing one ECG may not be conclusive. So maybe we'll have to take serial ECGs. So any definite interpretation of SCT changes without correlation with the clinical data and serial tracing is hazardous and unjustified. So we have to have a proper history of the patient as well as the serial ECGs. And when we talk of myocardial ischemia, how does it present on the ECG is symmetrically or deeply inverted T waves. There may be horizontal or downsloping ST segment depression with or without T wave inversion. If the previous ECG was showing inverted T waves and they become normalized, that is also suggestive of myocardial ischemia. So normalization of abnormal T waves suggests myocardial ischemia, and prolongation of QT in addition to the above suggests myocardial ischemia. So these are few indicators on the ECG to suggest myocardial ischemia. Now this is one sort of in the ECG where you can see horizontal ST segment depression. When we say ST segment depression, normally there is an isoelectric line which correlates to the TP segment. There is a T wave and followed by a P wave. So that is a TP segment which is taken as an isoelectric line. This isoelectric line, this is also a TP segment. Now after the T wave, before the next P wave comes, that's the TP segment. So we take this TP segment as the isoelectric line. From this isoelectric line, there is an ST segment depression, which is an horizontal ST segment depression. And in this ECG, the second ECG, there is a downsloping ST segment depression followed by inverted T wave. And the T wave is symmetrical T wave. So there is a typically horizontal or downsloping ST segment depression, which is a sign of some endocardial ischemia or non-QMI. Following T waves, following T waves might be upright or inverted. They last for minutes or hours or days, depending upon the symptom, and often last longer in patients with unstable angina. Now, this is one ECG again showing horizontal ST segment depression. There is downsloping ST segment depression in lead 2, and as well as horizontal ST segment depression in ABF, and horizontal ST segment depression in V3, and downsloping ST segment depression in V4 to V6. So this is an ECG of horizontal ST segment depression with or without T wave inversion. And once the patient symptoms improve, the ECG normalizes. So you can see wherever the ST segment depression was there, either horizontal or downsloping, it has normalized after the patient symptoms have disappeared. So this is myocardial ischemia. There is no damage to the heart, which is termed as myocardial infarction. So, and the inverted T waves, the routine interpretation of symmetrically or deeply inverted T waves as a sign of myocardial ischemia without considering other possibilities is one of the most common errors in the electrocardiography, often leading to undesirable consequences. So again, going back to, we have to have the history. Suppose a patient is of hypothyroidism. He may be having SCT changes. He doesn't have any chest pain, and we just see the ECG. And if we know the history, then we can say this STT changes are because of hypothyroidism. Or if somebody is suffering from cardiomyopathy, again, patient may not be having any chest pain, but ECG may be showing STT changes. So the history is very important to diagnose. And suppose if there is a 20-year-old boy who comes with an ECG, which is showing the STT changes, and there's no history. And when we see the serial ECG, again, all the ECGs are same, then we know this ECG is of early repolarization. So again, I think I'll keep on emphasizing that taking history is very, very important as far as the ECG interpretation is concerned in the acute coronary syndrome. So symmetrically or deeply inverted T waves may be because of myocardial ischemia, or nowadays we do not use this term of non-QMI, which is also called as NST-MI, no ST elevation MI. So these are the symmetrically or deeply inverted T waves can be seen in myocardial ischemia or non-QMI. Now this ECG, you can see a deeply inverted T waves, which are the symmetrical T waves from V1 to V6. And this is, if there is a history suggestive of angina, then we know that this is a myocardial ischemia. But such an ECG can also occur in a condition called as hypertrophic cardiomyopathy. So if we know the history, then we know whether this patient is subject to a case of myocardial ischemia or a case of hypertrophic cardiomyopathy. Sometimes similar ECG may also be seen in patients who are having subarachnoid hemorrhage. So patient, if he comes in coma with neurological problems, and if we see such an ECG, then we know this ECG is not of myocardial ischemia, but is of subarachnoid hemorrhage. So again, history taking is very important. Seeing the condition of the patient is very important. Then we have to interpret the ECG. But if the patient has presented with severe chest pain, retrosternal, and this is the ECG, then likely we are dealing with myocardial ischemia. Then we see some non-specific STT changes where ST is slightly depressed and T wave is low, flat, or slightly inverted. These non-specific STT changes are very, very common in clinical practice and may not signify myocardial ischemia. We see such changes, and especially in females, and hypothyroidism, and various electrolyte disturbances, or patients taking certain drugs where we can have these non-specific STT changes. So the diagnosis of MI depends upon the ECG changes, their symptoms, and the enzymes. Enzymes estimation is also very important, especially if nowadays we do a TROP-I or TROP-D estimation. So if ECG symptoms and the enzymes are positive, that means the TROP-I or TROP-D are elevated, then we diagnose that this patient is suffering from myocardial infarction. Again, serial ECG and clinical correlation are mandatory in making the correct diagnosis of acute MI. Because one ECG, suppose somebody has suffered from old MI, maybe 6 months back, and you see the ECG, you do not know whether this patient is having an acute MI or not. So again, the history taking is very important, and the previous ECGs are there that will help you in clinching the correct diagnosis. Earlier, we have used these terms like transmural or subendocardial MI, where the transmural MI was thought to be QMI, and the subendocardial MI was non-QMI. But again, the QMI does not always correlate with transmural MI, and non-QMI does not always correlate with subendocardial MI. So now the terminologies have changed, and we have got ST elevation MI and non-ST elevation MI. So this is the correct terminology which shall be used in the current context. Now, how the ECG changes evolve in this ST elevation MI. So the first thing which happened is the tall T waves. This is the tall T waves are seen in first few minutes of acute coronary syndrome. Sometimes patient presents late, so normally this tall T waves are we miss out. Then the patient starts having the ST elevation. Then the abnormal Q waves have started appearing, and there is a decrease of ST elevation with beginning of T wave inversion. And then the ST elevation becomes isoelectric, and there is a symmetrical T wave inversion is there. And finally, the ST segment becomes isoelectric, the T waves become upright, and then only the Q waves remain. So this is how the ECG changes evolve in ST elevation MI. This is one ECG where you are again you are seeing a downsloping ST segment depression in lead 1 and AVL, and you are seeing horizontal ST segment depression from V2 to V6. So this is again showing this patient, if there is a history, then this ECG is suggestive of myocardial ischemia. Now, I have talked to you about abnormally tall T waves. These abnormally tall T waves are also called as hyperacute T waves, and this happens in very early stage of myocardial infarction, MI. In patients with ischemia, usually these tall T waves are usually symmetrical. They are transient or persistent and most commonly seen in precordial leads. QT is usually prolonged, and in inferior wall MI, I'll be talking about anterior and inferior wall MI in my slides, which will be coming soon, with the deeply inverted T waves may be accompanied by reciprocal tall symmetrical T waves. So we'll be talking about the reciprocal changes in MI. So you may have STT T wave inversion in the inferior leads, and you may see tall T waves in the reciprocal leads, that's the anterior leads. This is one ECG, again, of acute coronary syndrome, where patient has presented with severe chest pain, and ECG has been taken within minutes of his chest pain. And you can see very tall symmetrical T waves. Normally, you will not see such T waves. These type of T waves, normally there are only two conditions for the learners. One is acute coronary syndrome or acute myocardial ischemia. And the second is hyperkalemia. In hyperkalemia also, you see a very tall T waves. But in myocardial ischemia, these T waves are slightly rounded as compared to hyperkalemia, where they are totally pinched. So they're pointed. So in myocardial ischemia, these T waves are, if you see these T waves, are slightly rounded. So, or you can see here, they're rounded T waves and very tall T waves. And if you see carefully, there is a slight depression of the J point. So it's a depression of J point, which is at the end of QRS complex that is called as J point. So there is a depression of J point. Sorry. So there is a depression of J point and very tall T waves. And the history context, a patient has presented with chest pain. This is an acute coronary syndrome. And if we do not note or take a note at this level, then the next ECG, if you see, the ST segment are way high. The ST segment is elevated, way high, from V1, V2, V3, V4, V5, V6. So there is an extensive ST segment elevation, and this is ST elevation MI. So we have, if we catch the patient in a very early stage and give a proper therapy in the form of either thrombolytic therapy, or we do an urgent coronary angiography and send the patient for primary angioplasty, the myocardial viability will be much, much better if we give the proper therapy in early hours of the acute coronary syndrome. Now, ST elevation usually is seen in lead spacing MI. So if the ST segment elevation is there in inferior leads, that is lead 2, 3, and AVF, then it is inferior wall MI. If the ST segment elevation, like last ECG I have shown you from in the anterior leads, then it's an anterior wall MI. It is in larger area than the Q waves. The degree of ST segment deviation may vary. In inferior wall MI, usually this ST segment elevation resolve within 2 weeks, and almost 90% of the people within 2 weeks, the ST segment become isoelectric. But in anterior wall MI, they take more time. So in 2 weeks time, it resolve in approximately 40% of the people. And then it may resolve over a period of 1 to 6 months. And so the ST segment persists maybe for 1 to 6 months. And if it persists beyond 6 months, then the diagnosis of LV aneurysm should be considered. So I have talked to you about the ST elevation and how do we localize the MI. I talked to you that if the ST segment elevation is there in lead to 3 AVF, it is inferior wall MI. If it is in V1 to V2, we say septal wall MI. If it is V3 to V4, it is anti-wall MI. In V5, V6 and lead 1 AVL, it's a lateral wall MI. If we see the ECG ST segment elevation from V1 to V6, sometimes we use the terminology as extensive anterior wall MI. So these are the different terminologies are there. And I have talked to you about there is sometimes we see a reciprocal ST segment depression. So we are seeing the ST segment elevation in anterior leads. We may say ST segment depression in inferior leads and vice versa. So more pronounced in inferior than in anterior leads. And usually the conventional explanation is this is an electrical phenomena, but it could be because of the ischemia in other vessels territory. Like anterior wall MI can happen because of the left anterior descending artery block. So if the person is having also the right coronary artery obstruction, then he may be showing STT changes in inferior leads and more extensive MI involving the posterior lateral wall. Now, this is one ECG which is showing the ST segment elevation in V2, V3, V4, V5, V6, and you are seeing some ST segment elevation in lead 2, 3, and AVF also. So this is an acute inferior wall MI, as well as there is a suspicion of the lateral wall MI. So this is an inferior lateral wall MI, and you are seeing the ST segment depression in lead 1 and AVL. So this could be a reciprocal change, or it could be because of the left anterior descending artery obstruction also. Then, as I have showed you while showing the slide of evaluation of the ECG, the patient develop abnormal Q waves in acute MI. Usually it takes hours to develop, days to develop. Usually the Q waves starts appearing when the ST segment is still elevated, though it has started coming down, but the ST segment is still elevated. However, usually when the Q waves are persist, once the MI settles, and the presence of the Q waves tells that the patient is having an old MI. And in significant number of patients, they do not persist. Approximately 12 to 20% people, the Q waves also disappear. And sometimes the ECG may become totally normal even after acute MI, almost approximately 6% people. Until unless you have the history or the previous ECG, you may see a normal ECG after acute AMI. So where there were Q waves initially, 6% people will have totally normal ECG. So that is, I think one should remember. That's why the serial ECGs are very, very important. Again, we are talking of what is the Q wave criteria. Normally, the Q waves should be more than 0.4 seconds. That is one small square. The width of the Q wave should be more than one small square, and it should be at least 25% of the height of the R wave in a given lead. So that is important to know what is the pathological Q wave. And there are three exceptions are there. One is if you are seeing the Q wave only in lead 3 without in lead 2, then because normally we can see a Q wave in lead 3, so that is not significant. Again, Q wave in lead AVL also, if it is seen only in lead AVL, again if there are no other ECG abnormalities, then again it is of no significance. And sometimes we may see a small Q wave in lead V2 also without any other abnormalities. So these are the three exceptions of non-pathological Q wave. So this is one, again, an ECG of where you are seeing an ST segment elevation in lead 2, 3, and AVF. So this is an ECG of acute inferior wall MI, and you are seeing a reciprocal ST segment depression in lead 1 and AVL. So this is an acute inferior wall MI, and once the patient settles, once the chest pain settles, you can see almost a normal ECG, and then lead 2, 3 AVF and lead 1 and AVL. So this is sometimes the patient may not progress for acute MI even after ST segment elevation. So this is also called as a prismental angina, where there is an ST segment elevation in the acute phase, and the ECG becomes almost normal after a few hours. This is one ECG again. You are seeing an ST segment elevation in V1, V2, V3, and V4. So this is sometimes we call as anteroseptal MI, because this is septal and anterior. So anteroseptal MI, and over a period of time, this ECG becomes like this, where you are seeing just the Q waves in V1, V2, V3, and V4. And the ST segment is the normal. The T waves are upright. So this is an ECG of old anterior wall, old anteroseptal wall MI. So from ST segment elevation, and the patient has gone to old anteroseptal MI or old QMI, where you are seeing just the Q wave and you are not seeing an ST segment elevation or the T wave inversion. And in the AMI, the T wave inversion, that I've told you, the T waves begins to invert when the ST segments are decreasing or still elevated. And then T waves becomes progressively deeper as ST segments subside. And there is, and later on, the T waves becomes upright in old MI. And there is a one differential diagnosis of STT changes, where is acute pericarditis. In acute pericarditis, the T waves are not inverted until the ST segments are isoelectric. So once the ST segment becomes isoelectric, then you start seeing that inverted T waves. So this is one, again, an ECG. I'll be showing you many ECG, again an ECG, where you are seeing the Q waves in V1, V2, V3, and V4. And you are seeing slightly elevated ST segment in V1, V2, V3, and V4. And there are T wave inversion in V2, V3, V4, and V5. So this is an ECG again of maybe an acute MI, which is progressing towards an old MI, anteroseptal MI, with a lateral wall ischemia. You are seeing a T wave inversion in the lateral leads, so there is a lateral wall ischemia. This is one ECG. One has to see the ECG. If you are seeing the ECG, you see the ECG in lead 2, 3, and AVF, where you are seeing the Q waves in lead 2, lead 3, and AVF. If you are just seeing the Q wave in lead 3 and there are no Q waves in lead 2, not significant. But if you are seeing a Q wave in lead 2, lead 3, and AVF, ST segment is almost isoelectric. There is still a T wave inversion is there in lead 2, 3, AVF. So this is again an ECG of, maybe again we have to have the history, but this ECG is of acute inferior wall MI, which is going into the chronic phase or old MI. So as far as the terminology is concerned, we call an acute MI when the ST segment elevation is still present. We say subacute MI when the ST segment has returned to isoelectric line. So it could be a recent or subacute. And the terms can be used only when we have a series of ECG. And then old MI is usually the MI is known to exist for at least 2 months. So if there is a history of 2 months back, the patient had a chest pain, and then you see a Q wave and the T wave inversion in the ECG, then you say old MI. So history is important, and then the ECG is to be interpreted. Then we have got certain specific categories like right ventricular MI. Usually the right ventricular MI happens because of there are 3 blood vessels which supply blood vessel to the heart. One is the right coronary artery, the left anterior descending artery, and the left circumflex artery. This right ventricular MI happens because of the right coronary artery involvement. And usually the right coronary artery involvement leads to inferior wall MI. So normally right ventricular MI does not exist in isolation. It comes with inferior wall MI, as it is the involvement of free wall of right ventricle and rarely occurs in isolated form. And the prevalence in inferior wall MI is of right ventricular MI is 14 to 36%. The ECG criteria of RVMI is the sign. There has to be a signs of inferior or inferior posterior wall MI. I'll be talking about the posterior wall MI. There is ST segment elevation in one or more right precordial leads. Which are the right precordial leads? Usually V1 is the right precordial lead. But if we have to have typical or special the right precordial lead, then we have to have V4R, which is especially the right precordial lead. V4R is the replica of V2 on right side. And the ST segment elevation of 1 millimeter or more in the right precordial lead, that is V4R. The sensitivity is 88% and specificity 78%. This is in lead V4R. Then sometimes in the conventional 12-lead ECG may also reveal ST elevation in V1, which is again, I told you, it is considered as the right ventricular lead. So in V1, sometimes you may see a ST segment elevation in V2 and V3 also. So this is one cartoon showing an ST segment elevation because of proximal occlusion of right coronary artery, whereas there is a inferior leads. You are seeing a ST segment elevation of more than 1 millimeter, and the T wave is upright. While when there is a distal occlusion of RCA, there is no ST segment elevation with upright T wave, and in circumflex occlusion, you see a Q wave with inverted T wave. So how you diagnose right coronary artery or circumflex occlusion, even without having a coronary angiogram, they sometimes ECG can tell you which artery you are dealing with. Now, this is one ECG of right ventricular infarction where you are seeing the changes of inferior wall MI. You are seeing Q wave in lead 2, 3, and AVF, and you are seeing ST segment elevation in lead 2, 3, and AVF. And associated with this, you are seeing ST segment elevation in V1 with RSR pattern. This pattern is also quite diagnostic of right ventricular infarction. Then sometimes we get again a posterior myocardial infarction. Again, posterior myocardial infarction happens in the presence of acute inferior wall MI, and we see a sole R wave, initial R wave in V1 and V2. There is a sole R wave which is more than 0.04 second width. One small square is 0.04 second. So the R wave has to be more than one small square. And R wave is usually more than the S wave, and there is a ST depression with upright T waves. Usually it happens in the setting of acute inferior wall MI. Sometimes the right ventricular hypertrophy or WPW syndrome or right bundle branch block may also present similarly. So they interfere with the diagnosis of posterior wall MI. Again, I think the serial ECGs are again important. If we are having a right bundle branch block in the serial ECG, then we know okay, what is the cause of the present RSR pattern in the present ECG. This is one ECG again which is showing tall sole R wave in V1. So if there is a history which is suggestive of acute chest pain and you see such an ECG, then the diagnosis may be posterior wall MI, acute posterior wall MI. Now, sometimes we see left bundle branch block, and in presence of left bundle branch block, it's very difficult to diagnose acute MI. So there is a criteria which is called as Garbosa criteria for diagnosing acute MI in presence of left bundle branch block. What are these criteria? There are 3 criteria that are there, and we give 5 points for criteria number 1, 3 points for criteria number 2, and 2 points for criteria number 3. So if there are more than 3 points, then the diagnosis of acute MI is established. And if less than 3 points are there, then the diagnosis is doubtful. So what is the most important criteria is ST segment elevation of 12 millimeter or more, concordant with QRS complex. So if the QRS is upright and if we see an ST segment elevation in the same direction, then we say the patient is having acute MI. Similarly, if there is a ST segment depression of 1 millimeter or more in leads V1, V2, or V3, because in left bundle branch block, the Q wave is, or the QRS complex is inverted or it is downward. So if you are seeing ST segment depression, again, it becomes like a concordant ST changes. So if you are seeing an ST segment depression in V1, V2, V3 of 1 millimeter or more, again, it is suggest acute MI. And if there is an ST segment elevation of 5 millimeter or more, discordant with QRS complex, means it is in opposite direction. If suppose then the QRS complex is downward and you are seeing an ST segment elevation of 5 millimeter or more, it may suggest an acute MI, but it is a weak point. Now this is an ECG of left bundle branch block where you are seeing wide RS complex in V1, and normally there is an RS complex in V6. But here what you are seeing, in there is an ST segment elevation in V5 and V6, which is concordant with QRS complex. The the QRS complex is upright, and even the ST segment elevation is upright. So it is in concordance with QRS complex. So this is very diagnostic of, if there is a history, then it is very diagnostic of acute anterior wall MI. Similarly, in other ECG, again you are seeing left bundle branch block. You are seeing a wide QRS complex in V1 and wide RS complex in V6, which is very typical of left bundle branch block. And in the same patient, if you see it carefully, lead 2, 3, and AVF, in the same direction of QRS complex, you are seeing an ST segment elevation in lead 2, 3, and AVF. So this is again very much suggestive of acute inferior wall MI in the presence of the history. So now, just to conclude, ECG is most useful, feasible diagnostic tool for initial evaluation, risk stratification, triage, and guidance of therapy in patient with chest pain. Should always be correlated with clinical settings and enzyme levels. ST depression and T-wave changes can occur due to so many other causes I have talked to you. And the localization of culprit vessel can be performed fairly from the ECG. So if you are seeing an anterior wall MI in from ST segment elevation in anterior leads from A1, V1 to V6, then the culprit vessel is left anterior descending artery. And if you are seeing an inferior wall MI, where you are seeing an ST segment elevation in lead 2, 3, and AVF, so it could be right coronary or left circumflex artery. And if you are seeing an ST segment elevation more in lead 3 as compared to lead 3, then it is the right coronary artery involvement. And if the ST segment elevation is more in lead 2 as compared to lead 3, then it's a left circumflex artery. So seeing an ECG properly, one can even localize the culprit vessel on ECG. I'll just show you 1, 2, 3 more ECGs. Again, you are seeing an ECG where you are seeing the QS complexes, or there is a failure of R wave to rise, and you are seeing Q wave, lead 1, lead 2, lead 3, lead 4. So this is an ECG of old, or again, the history is important. This ECG could be an acute or progressing to old anteroseptal wall MI with lateral wall ischemia, because you are seeing STT changes, T-wave inversion in lead 1, AVL, V5, and V6. One more ECG where you are seeing an ST segment elevation in lead 2, 3, and AVF. And also you are seeing an Q wave with ST segment elevation in V4, V3, and V4. So this is an ECG of acute anterior wall MI. If there is history, this could be acute septal anterior wall MI, or this could be an old anterior wall MI. Again, then there's one more ECG where you are seeing QS complexes from V1 to V4, V5, and even in V6, and you are seeing an ST segment elevation, and ST segment elevation is still present in V5, V6. So this is likely to be acute extensive anterior wall MI, where the septal, anterior, and lateral wall is involved. So sometimes when we see such an ECG, we say an acute extensive anterior wall MI. This is one more ECG if the history is there, and you are seeing an ST segment elevation in lead 2, lead 3, AVF, and V5 and V6. So this is an acute inferior lateral wall MI, inferior and lateral wall MI, and you are seeing ST segment depression and lead 1 and AVL. So this could be reciprocal changes. I think that's all. So this is about my talk.
Wonderful. Thank you so much, Dr. Gupta. It was a pleasure to hear you, and I'm sure it would be so from the audience.
I think I have taken about 40-45 minutes. So I'll just stop sharing the screen.
We would have the audience Q&A
Yeah, so I'll be happy to answer.
Yeah.
I thought I have kept my talk as basic as possible, but still
I'm sure it was quite detailed, sir, because I'm sure a lot of queries of people, including left bundle branch block, and a lot of those perspectives were
so
touched upon.
because in one day one cannot learn all about ischemia and infarction. It has to be day-to-day practice. So one has to keep on seeing the ECG correlating with history. So it's very important. But I have tried to keep my talk as basic as possible. Yeah.
So what I do get from here is we have had a very interactive audience with a couple of questions.
Yeah, sure.
So if we can go ahead with some of the same.
Sure.
So you did touch upon one ECG wherein you showed Prince metal angina with an ST elevation.
Yeah.
So can you throw some light on such kind of reverse ECGs? Example, a posterior wall MI. You did mention it in your talk, but would you want to just throw some light on difficulty in diagnosing a posterior wall MI?
See, patient presents with chest pain. So there could be an acute coronary spasm where there is no obstruction. So sometimes when there is maybe because of severe stress, the coronary goes into the spasm without any fixed obstruction, and that acute coronary spasm behaves like an obstruction and presents an STT changes. But within a short time, this coronary spasm goes away, the flow of the blood vessel maintained, and the ST segment comes down. So this is called as prismental angina. And so that ECG I have shown you. And posterior wall MI, again, when there is a right coronary artery involvement is there, which is sometimes a dominant coronary artery, we say, again, this terminology we use, which blood vessel is supplying more blood to the heart. So if the right coronary artery is a dominant blood vessel and supplying blood to the heart, and if there is a proximal occlusion of right coronary artery, so it may involve the posterior wall. So normally posterior wall MI comes with an acute inferior wall MI, and there is a sole R wave seen. It's a posterior wall which we do not see on the ECG. So when we are seeing an ECG, so we see on the opposite side of the posterior wall. So we see a tall R wave in V1, and that's how we diagnose a posterior wall MI.
So you, in your talk, you also discussed on the evolution of an ECG in a typical STMI. Right from the hyperacute T wave changes to later it settling down along with the ST elevation, finally with the formation of a Q wave. On the same note, Dr. Sundar Chapagain from Nepal asks, how can we determine the time passed following an MI by looking at an ECG?
I told you, that's the, I again repeatedly, I must have talked at least in my talk 10 times. Absolutely. That until unless we have the history, we cannot, I have shown you 2, 3 ECG, 4 ECG at the end of my talk. If when somebody gives me this ECG, to me also, I cannot tell if this ECG belongs to acute MI or it's an old MI. Until unless somebody gives me the history, that patient had a chest pain about 3 days back or 7 days back, and this is the ECG. So then I can say this is a resolving acute MI. Or if the patient had a chest pain 2 months back, then I can say it's an old MI. Or if the person has chest pain 3 days back, then I know it's an acute MI. So the history is very, very important. So I will tell all my audience, do not read the ECG without knowing the history. So you have to have the history before reading the ECG, because you may read an ECG of a 20-year-old boy who doesn't have any symptoms. He runs for 4 or 5 kilometers. You are seeing some ST segment elevation and you say it's an acute MI. Not the case. It is an early repolarization syndrome, and you keep on seeing serial ECG, all the ECG will remain like that. So one has to have a history, I think very important.
So considering the fact that you mentioned history and interpretation of the ECG in the light of the same, our next question from
history, ECG, serial ECGs, and the enzymes. I think on these 4 things are very, very important.
So the next few questions are on the same note. So a question we've received is an asymptomatic diabetic with his duration of diabetes since 10 years with uncontrolled hypertension comes and visits the doctor, and he is an asymptomatic patient, just has a T wave inversion in lead 3 and AVF, no other STT changes. What should be done next?
Usually lead 3 and AVF, normally you can see a T wave inversion, normally. So until unless it is associated with lead 2, usually we may not give any significance to STT changes if they are just present in lead 3 and AVF. But if the ST segment depression is quite noticeable, then even in hypertension, you can have ischemic changes either in inferior leads or in the lateral leads V5, V6. So this could be just a strain pattern of because of left ventricular hypertrophy. So patient is, as ST has mentioned, that patient is diabetic and hypertensive. So this could be either a normal variant or it could be STT changes because of hypertension.
So, Dr. Naylin asks, Dr. Naylin from Myanmar asks, how about sinus tachycardia, plain sinus tachycardia, in a patient below 35 years of age with chest pain and no other abnormalities? He's not mentioned whether it's a cardiac chest pain or a non-cardiac chest pain. Probably that aspect is not dealt with. But your take on the same, sir. What should we do?
Again, I think some basic things we have to have. There are, once we see chest pain, normally when somebody comes with the history of chest pain, I try to classify this chest pain into three categories, whether it's a non-cardiac chest pain, whether it's a atypical angina or it's a typical angina. Normally, typical angina is a patient who complains of chest pain retrosternal, which comes on exertion, raise on taking rest, or relieves by taking nitroglycerin. So this is typical angina. Sometimes when the chest pain is very non-specific, that patient is complaining of chest pain on the left side, also on the right side, also on the shoulder, which is non-exertional. It remains for hours or days together. And so this is a sort of a non-cardiac chest pain. And when there is a chest pain where you are not very certain whether it could be a typical or non-cardiac chest pain, then you say it's atypical chest pain. So I think, again, history is very important. And sinus tachycardia can be a manifestation of coronary artery disease in the early stage. But there are many causes of sinus tachycardia, even with somebody is having chest pain. A lot of young people, they come to my clinic who are having chest pain and they are so anxious. They feel they are having acute MI and they are having tachycardia. So, but they don't have anything. So tachycardia is a very non-specific thing. So this could be because of maybe the anxiety, or there may be an underlying hyperthyroidism, or there could be many causes of tachycardia. But again, taking a proper history will be very important. And I think categorizing chest pain, whether it's a NCCP, non-cardiac chest pain, atypical angina or typical angina, will be very useful.
Sure, sir. So another question we've had is that many patients coming to the emergency, especially with an anterior wall MI, tend to arrive with a tachycardia and a hypertension, while many patients coming with an RVMI and inferior wall MI because of the high vagal tone tend to come with a bradycardia and a hypotension. So your take on the same, and how should we look at both these entities from an ECG perspective? Of course, you have dealt with this in detail, but your final pearls of wisdom on the same.
Basically, the right inferior wall MI and RVMI, I've told you that it occurs because of the involvement of right coronary artery. The right coronary artery supplies the SA node and the AV node, the sinoatrial node and the atrioventricular node. These two nodes are giving rise our sinus rhythm. So if there is an ischemia of SA node or AV node, the patient will have bradycardia. Or there could be first degree, second degree, or third degree SA or AV blocks. So in inferior wall MI, these blocks or the conduction differences or disturbances are very common. In the anterior wall MI, there is a huge myocardium is involved. The LV is involved. So because of the huge large amount of myocardium is involved, the cardiac output decreases, then the tachycardia occurs. So in anterior wall MI, that there will be tachycardia because of, again, it tells you that there is a extensive myocardial involvement if there is a tachycardia. And bradycardia in inferior wall MI is because of the involvement of SA or AV node vascular deficiency.
So thank you. So the last two questions for the day. So what are the fallacies, the common fallacies faced while interpreting an ECG for a myocardial infarction? What should not be missed as per you?
I think the most common fallacy, I'll put it to first, seeing a normal ECG with acute chest pain. Patient is having acute coronary syndrome, and when you take an ECG, it's a normal ECG. So if history is very typical and ECG is normal, then you take this patient is having an acute coronary syndrome, you have to keep the patient under observation. Take serial ECG. Maybe after, if you take an ECG after half an hour or after 1 hour, the ECG will show the signs of acute MI. So the most common fallacy, I'll say, a normal ECG in the presence of typical acute chest pain. And so doing a serial ECG and doing a serial enzyme estimation will diagnose an acute MI. So be careful that if you see a normal ECG in presence of typical chest pain, do not let the patient go home. Keep him under the observation at least for 6 hours. If after 6 hours also the ECG is normal, then you can safely send the patient home. We ask him to come back again for evaluation of chest pain by doing certain tests like stress tests, etc. So this is very important. And then the other fallacies are, I have told you, there are so many conditions like hypothyroidism, electrolyte imbalance, etc., which can produce STT changes, which can mimic like an acute MI. Early repolarization syndrome can mimic like an acute MI. The most common diagnosis, which almost mimics like acute MI, is acute pericarditis, where you can see generalized STT changes with T-wave inversion. But here, if you see a serial ECG, you will never see an ST segment elevation in acute pericarditis, and ST segment depression is universal, like in inferior leads as well as in anterior leads. So this is very, very important too. And again, patient may be having chest pain for hours together, with maybe associated with fever, etc. So that's how you diagnose acute pericarditis. So these are certain fallacies. And if you take again a proper history and see a serial ECG, then you'll come to know whether you are dealing with acute MI or some other diagnosis.
Sure, sir. Sir, our last question for the day is from one of our doctors in Nepal. So, as you rightfully said about systemic diseases also altering ECGs, you mentioned about hyperthyroidism manifesting with either a sinus tachy or an atrial fibrillation. We also know that patients with COPD can sometimes have a multifocal atrial tachycardia or a P pulmonale. So, what are the changes that occur in a patient with stroke is what Dr. Paras Manibhatta from Nepal asks.
Basically, in all type of strokes, usually the ECG does not occur, but patients who are having subarachnoid hemorrhage, you may see STT changes in anterior leads. And you may see deeply, I have shown you one ECG and during my talk where you see a deeply inverted T waves from V1 to V6. And if you take a proper history and the patient comes in a comatose state with maybe signs of meningeal irritation, with no previous history of MI, and you are seeing such an ECG, I think just hold on. Do not diagnose an acute MI in such setting, and take serial ECGs. These ECG may revert back to the normal if patient survives. So, so you see inverted T waves and sometimes mild ST segment depression from V1 to V6, and especially in subarachnoid hemorrhage.
Thank you so much, sir. On the same note, thank you very much for solving all our queries, sir. I now hand over the session to the Head of Medical Affairs of Macleods Pharmaceuticals, Dr. Amit Kamra, for the corporate overview. Over to you, sir.
Thank you, Dr. Gupta and Dr. Parthsarathy, for the enlightening discussion. It was indeed a pleasure. And my special thanks to our audience. And before that, let me greet you all from Mumbai in India. And I'll just take 2 minutes and brief you about our organization, like who are we and what do we do. So, good evening, one and all. We are from Macleods, and we are truly a vertically integrated pharmaceutical company. We are amongst the top 10 pharmaceutical players in India, and put together, we employ more than 17,000 employees from multiple backgrounds. into our organization. When we see the globe, we supply our products to more than 170 countries in the world. And moreover, we operate in all the therapeutic segments. Here in India, we operate by more than 10 commercial divisions. We have 8 strong plants. Within those 8 strong plants, there are 13 finished dosage manufacturing facilities, and we have 2 API manufacturing sites with 6 blocks. This all is supported by a strong research and development center at Mumbai and Ahmedabad. So we are a 37-year young organization. We were formed in the year 1989, and in the year 1991, our first plant was formed in Palghar. This plant was approved by EU in the year 2007, and our recent manufacturing facility was opened 2 years back in Indore, whose focus is only and only to manufacture for exports. This is the world map, and as you can see that the areas in light green reflect the places where we manufacture our own products. These places are India and Indonesia. The places in dark green are our offshore repackaging and manufacturing sites, which is Indonesia. Areas in maroon represents our subsequent joint ventures, which includes the United Kingdom, the United States of America, Ukraine, Spain, Nigeria, South Africa, Malaysia, Philippines, Kenya, Kazakhstan, and Russia. Talking of our direct field force operations outside India, our own field force are present in French-speaking West Africa, East Africa, Myanmar, Sri Lanka, and Nepal. And the areas in blue represent the areas of the globe where we operate through our distributors. So we have strong international presence in more than 170 countries. All this is made possible by 8 manufacturing units in India, which is Sarigram, which is our mother plant, which supplies APIs to all other plants. Then we have 3 units in Daman. We have a unit in Baddi, Sikkim, and Palghar. And the recent addition has been Indore in central India. So talking of our business model, we follow all the business models, be it institutional, non-institutional, third-party supplies or subsidiaries. And as an organization, we have approval from the leading global regulators, which includes but is not limited to US FDA, UK MHRA, EMEA in Europe, the Health Authority of Brazil, South Africa, and WHO Geneva. So our key value proposition has been that we have leadership in India. We are supported by strong infrastructure, which is backed by our 8 plants and research and development. We are present in almost every country, and all this is managed by a strong financial and management excellence. Talking of our research and development center, we have a dedicated research facility in Mumbai, which operates by 6 units in Mumbai, 2 in Sarigram, and 1 in Ahmedabad. These facilities are duly inspected by all the leading health authorities, which includes WHO, Geneva, US FDA, to name a few. We also have a state-of-the-art bioequivalence center in Mumbai, which is a 250-bed center hospital. It has been successfully inspected by all the leading health authorities, which includes US FDA, WHO Geneva, UK MHRA, the South African health authorities, etc. This center has a well-equipped emergency care unit, path lab, and analytical section. And in the last 10 years, we have carried out more than 2,500 bioequivalence studies in our center. Talking of what we manufacture virtually all the formulation, which includes tablets, hard gelatin capsules, soft gelatin capsules, liquid orals, powder for oral suspension, dry powder inhalers, pressurized metered dose inhalers, the topical formulations, and the dry powders for injection. What are we interested in going forward? We are interested in topicals and further inhalation formulations. And what do we see as our growth? We see our growth as liquid injectables, which includes the small molecules and the peptide, and the potent products for tomorrow, which includes oncology as well as non-oncology products. Talking of our dossiers and approval in Europe, we have 59 dossiers filed, out of which 41 have been approved and 38 molecules have already been commercialized. Talking of US, we have 180 abbreviated new drug applications, which is a US FDA approval process, out of which 62 molecules are commercialized in US. What is our growth strategy? As you have seen that we fundamentally believe in building capacity, we believe in backward integration, we believe in expanding direct presence in multiple geographies, we believe in launching much more innovative formulation, we believe in entering into new therapeutic segments like oncology, and continuing to retain our focus on the current products. And you can see that all this is done under one roof, and therefore we are the proud leaders amongst the industry. We are proud manufacturers of APIs, finished pharmaceutical products, which is backed by a strong research and development team and the patents team as well. With this, I would like to pass over to Mr. Rohit Gupta to give us a vote of thanks. Over to you, Rohit.
Thank you so much, Dr. Gupta, Dr. Kamra, and Dr. Partha. I think it has been indeed a pleasure to have such an audience. We have more than 200 doctors online who attended this program. So thanks to the medical fraternity that took over time on a weekend and attended this program. This also tells us that there is so much to learn for everybody, and medical fraternity is always coming forward for such kind of learning programs. I thanks to one and all, and we definitely look forward to associating in a much bigger manner with all the doctors from Sri Lanka, Nepal, and Myanmar. Thank you, everybody, and we look forward to visiting you and handing over you the detailed recording of the whole program, and look forward to doing such more programs in times to come. Thank you so much. Have a nice evening and good night.
I think I also wish to thank all of you from the Macleods, Mr. Ravindran Nayak, and all the audience who have participated in today's webinar. And if there are any feedbacks are there, it can be sent to me so that I know what are the things which can be modulated for future talks. So if there are any feedbacks, kindly let me know. So once again, thank you all. Thank you very much.
Thank you, Dr. Gupta.
Thank you, Dr. Partha Sarthi, especially.
Thank you, sir. Thank you, Dr. Gupta, sir.
For moderating the session.
Thank you, sir. It was a pleasure and an honor, sir.
Thank you.
Thank you, sir.